Hello guys, so this is your ophthalmology guru Dr. Niha Aggarwal and I'll be talking about the INI CET ophthalmology questions. So before starting with the questions, I would like to say that all these questions have been framed on the basis of the recalls, whatever the inputs we have got. So obviously there can be some errors based on the recalls regarding the language of the question, regarding the options or the images, whatever are there. So I think there is no need to get panicky or tense about it. The ultimate purpose of this discussion is to get into the touch that what kind of questions were asked and what should be the approach solving these questions and what are the high-yield topics that are a must before your next exam. So let's get started. The first question is, iritis is seen in all except. Now, though I got this question in this form, many of the students said that it was in a all except MCQ, but I personally feel that it would have been better if they would have asked it in iritis is seen in which options. Nevertheless, the question was asked like this, so we are going to deal in this manner only. Now, if you see iritis, okay, iritis is actually a part of the, it is a part of the iridocyclitis, right? And iridocyclitis is nothing but the anterior uveitis. So wherever you are getting the anterior uveitis, you can expect that iritis will be present there. Like for example, what we discuss in the classes, acute anterior uveitis with the arthritis. So there is a DT that we always discuss for the cases where we have acute anterior uveitis associated with arthritis. So here the first is your ankylosing spondylitis, if you remember, and always it is better to remember in this order only because somewhere it sticks to the mind that this is the most common one if you are learning the right order. Then we have got what you call as the Ritter syndrome. Ritter syndrome, these are HLA B27 positive, HLA B27 positive. Then we have got the inflammatory bowel diseases, we have ulcerative colitis as well as the Crohn's disease. Then next to follow is your psoriatic arthritis, and finally we have something called as a juvenile rheumatoid arthritis or juvenile chronic arthritis. Okay, now if you look in the options, they have already given you the ulcerative colitis and the psoriasis. So these two are ruled out because you are definitely getting the iridocyclitis here. Now, one of the option they have given is your Behçet's disease. Okay, now this is not associated with the arthritis, but we know that this is having HLA B5 positive HLA association, and it is actually characterized by a triad. So basically we get ulcers here. Oral ulcers are there, which are called as the Ephthus ulcers. Okay, then we have got the genital ulcers. Genital ulcers are also there, and along with this we have uveitis. So though we can get the granulomatous pan uveitis here, but an important kind of uveitis that we are seeing in cases of the systemic diseases. Okay, we are studying the uveitis in the systemic diseases, and one of the important ones is the Behçet's disease. So you have the uveitis here, so we can also rule out this that it is also having the iritis. Then apart from this, what are the other systemic diseases where you have uveitis? Like, to complete the list, we have sarcoidosis. Then we also have the toxoplasmosis, sarcoidosis, toxoplasmosis. Then we have the Behçet syndrome. So there are so many signs which are important. Like in cases of the sarcoidosis, we have the candle wax droppings. Now, if you remember, I always tell you that it is just like a spring season. Uveitis is just like a spring season. So many signs and symptoms, and see, they have asked you a question on that. So sometimes, little things are also asked like a big question. So, and one thing more, question is not difficult. It is the options that make it difficult. So here the problem is not in the question. Again, the problem is in the options. So they are such a close option. So I'll try to analyze them. So we have got the candle wax droppings. In the toxoplasmosis, we have the headlight. Headlight in the fog appearance. Headlight in the fog appearance. This is there. So you have got different things. So that means if you look here, we have already ruled out the ulcerative colitis, psoriatic arthritis and Behçet's. So you have got two options left now. So I think this is the easiest way of doing the things. As I always say, the diagnosis of exclusion, you can get into the answer even without knowing the slightest idea of those options also. So if you go by this way, you already know that iritis is a part of iridocyclitis, is definitely present in ulcerative colitis, psoriatic arthritis and the Behçet's disease. So if I have to give two answers, then obviously the answer will become A plus B. Now, having told you this, I want to show you something else also. I know that will increase your problem, but you should know the right information, because you know next time the same question could be asked with a different option. So this is my responsibility. I think that I should tell you the one more thing. Now see, if you remember the Parsons series that I am sharing, so if you look at this Parsons table, now see, this is one textbook that you cannot ignore at your level. So your Parsons book says clearly that the rheumatoid arthritis, see, most of the people say that it is the juvenile rheumatoid arthritis that is associated with the anterior uveitis and arthritis, but this table says rheumatoid arthritis also shows the iridocyclitis. It shows the iridocyclitis, and not only this, even they are saying that SLE is also showing iritis, and not only iridocyclitis, they have directly used this word iritis. So if you look in this perspective, answer should be none, and this is not new. Previously, so many times also we have been getting such questions in the institute's examination where the answer was none, okay, but you have to mark something there. You will not get the marks for marking the none, but you should know the right thing. These are the two which are having the least chances of iritis and iridocyclitis. Moreover, you are having the other features which are more important. Like for example, if I talk about the rheumatoid arthritis, then obviously if I ask you, you will say that dry eye is much more common. Yes, dry eye, scleritis, episcleritis, these things are much more common. We are not talking even about the iridocyclitis in cases of rheumatoid arthritis, but if I talk theoretically, it can be present. Okay, then if I talk about the systemic lupus erythematosus, again the most common thing that you are getting here is episcleritis, but it can show iritis. It can show iritis, and these flowcharts are really important. They're just like your NCERT. Sometimes you're getting question being lifted from there, and that is why I try to show you and include those things in our talks also, because you know even for your internal exams as well as your PG examinations, you cannot ignore these texts. So Parsons is the standard textbook of ophthalmology. So in that sense, it can be present in all. So if it was a question that it is present in, then the answer would have been all. It can be present, okay, but because they are asking a all except kind of a question, and minimum two options they are wanting, in which I should say that there is no iritis. Therefore, I will say that the answer will be A and B. Now, if I have to choose one, suppose they are saying that you have to select one, then go with the SLE. This is your rarest. Rarest to get is in the SLE. Now, rheumatoid arthritis, I am considering because, you know, at least it is giving you in the juvenile rheumatoid arthritis. It is common in juvenile form. So that's why I'm giving a grace that if you have to mark one, because we do not know the exact scenario, but whatever we got from the maximum feedbacks, they said that maximum they were minimum they were asking two. So minimum two if they are asking, then your answer is SLE as well as the rheumatoid arthritis. But if they had the option of one, then I will go with with the SLE because rheumatoid arthritis in juvenile form is actually commonly showing you iritis. So I hope everything is clear, crystal clear. Okay. Now coming to the next question, which of the following statements is false regarding the progression of the ocular hypertension to the primary open angle glaucoma, POAG? So I don't know what has happened to them. They are not asking the questions on the cataract of late. They are asking questions on glaucoma. And as I always say, anti-glaucoma drugs is a high yield topic. All the time it is being added in your, high list topics also. So they are asking about glaucoma. Now, if you remember, what is the terminology? We always discuss this. So I will say that glaucoma is actually frequently characterized by a triad. And what is this triad? We have raised intraocular pressure. What is the normal range? It is 11 to 21 mm of the mercury. Then we have the optic disc changes, and then we have the visual field defects. So these are the three criteria, and we require at least two criteria out of the three. Out of the three criteria, I require at least two criteria in order to call it as glaucoma. Okay, that means if I have only one criteria present, if there is only raised intraocular pressure, if the person is having only raised intraocular pressure, there is no optic disc changes and there are no visual field defects, okay, then I will not call it as glaucoma because there is only one of the criteria that is present here. Then this is called as ocular hypertension. So be very, very clear with your terms. Ocular hypertension is nothing but the presence of the raised intraocular pressure, okay. And if I have got the optic disc changes, okay, another scenario, optic disc changes plus the visual field defects, okay, but we have got the normal or low IOP. If I have got the optic disc changes, I have the visual field defects, I can see the changes of glaucoma, but the intraocular pressure is normal or the intraocular pressure is in the towards the lower side, then this is called as the normal tension glaucoma or the low tension glaucoma. Then this is called as normal tension glaucoma or the low tension glaucoma. And you know, POAG is actually the most common type of glaucoma. That is why I think they are asking so much about this glaucoma. So this is the most common type of glaucoma, and about 16% of the people, 16% of the people are actually manifesting in the form of normal tension glaucoma. It is 16% who are manifesting with the normal tension glaucoma. Now there are certain school of thoughts that whether we should treat, okay, before looking at the options I want to discuss about it so that we can have an effective interaction about the options. So are there any chances of the conversion of this ocular hypertension in the primary open angle glaucoma? So yes, ocular hypertension people have the chances of conversion of the primary open angle glaucoma if they have got the high risk factors. So if they have the high risk factors, then we have to what you call as treat them, because they have the chances of getting converted into POAG, frank POAG. So what are actually these high risk factors? You have to see this. So first important thing, as I always try to relate it with the alphabets, one is A. A is for aging. So as the age will increase, there are more and more chances that the person having the ocular hypertension can go into primary open angle glaucoma. Then B is the big IOP. So if IOP is quite more, that is more than 30 mm of mercury. Like normal range, you know, is 11 to 21 mm of mercury. So if I am having quite a big IOP, that is more than 30 mm of mercury, again it's a high risk factor, and this person has more chances of getting converted into your POAG. Then coming to third is C. C is the central corneal thickness. Central corneal thickness. So if I have central corneal thickness which is less than 550 microns, if it is less than 550 microns, so in a way I can say if the person has a thin cornea. If a person has a thin cornea, then we have more chances that the patient will be getting converted into POAG. Then coming to the fourth is with D. So increased CD ratio. If I have increased CD ratio which is more than 0.7. So CD ratio, you know what is a normal CD ratio? Normal is 0.3 to 0.4 and it can go even up to 0.6. So if it is more than 0.7, then it is definitely high and it's a high risk factor that this person can be converting and predisposing towards the open angle glaucoma. Then number 5. If we have the splinter hemorrhages, if the hemorrhages are also present, splinter hemorrhages over the optic disc, obviously that is also a sign towards the raised intraocular pressure going much beyond, because only then the capillary leaks will be there and you are going to see the hemorrhages. So if there are hemorrhages over the optic disc, I can get the high risk. And then I have something called as the pattern standard deviation. So if I am having this pattern standard deviation, this is PSD. So if this is also getting increased, so when do you get this? Increased pattern standard deviation, this is obtained on the Humphreys. Okay, Humphreys analyzer. So these are your 6 points which are called as the high risk factors. Very, very important. And if you remember, I keep on saying this in classes also, the risk factors are most important. They are always asked. Risk factors of glaucoma, diabetic retinopathy, retinal detachment, cataract, everything. Okay. So whenever the patient has ocular hypertension along with these high risk factors, I must say, if the patient is having ocular hypertension along with the high risk factors, this person should be treated on the lines of POAG. Then nothing, we have to treat this patient on the lines of POAG only, because there are so many chances that this person will develop POAG ultimately. While there is a second thing, when the person has the only low risk factors, or I can say high risk factors are not present. So ocular hypertension is there, but person does not have the high risk factors. We have only those risk factors which are the risk factors of POAG itself. Now, what are the risk factors of POAG? So number 1, if the person is having the family history of glaucoma is there. Okay, or we have diabetes, hypertension, smoking. These are the common risk factors. Then we have got myopia. We have myopia, or what you call as thyrotoxicosis. We have thyrotoxicosis. And then we also have what you called as the steroid response. Okay, if the person is taking the steroid. So steroid responders, those who actually show increase in the IOP due to the steroids, they are called as the steroid responders. So I will not say that they are not the risk factors. They are the risk factors, but they are just the low risk factors. They are the risk factors of POAG, but they are not having extra risk of conversion. They do not have the extra risk of conversion from the ocular hypertension to the POAG. So they have the risk of glaucoma in itself, but they are not having the added risk that their ocular hypertension can get converted into POAG. So this is the basic that you should know. Now, if you see this question, what they are trying to say in this question, which of the following statement is false? Okay, so let's see which is a false statement. The option number A is reducing the IOP is effective in delaying the incidence of POAG. So this is actually a true statement. Obviously, I told you, if you look here, IOP. IOP is a high risk factor. Can you see here? So if IOP is more than 30 mm of mercury, certainly this person will have more and more risk of getting converted to POAG. So what is the solution for this? I should decrease the IOP. So if I decrease the IOP, will this decrease the incidence of getting converted from ocular hypertension to POAG? Yes, definitely yes. So this is a true statement. Then coming to the second one, thin cornea is a risk factor for the POAG development. So this is again certainly a risk factor. We have seen in the C that the central corneal thickness also matters. So if this thickness is less than 550 microns, then this thin cornea can again be a high risk factor for the conversion from the ocular hypertension to POAG. So that means this is also a true statement. So this is also a true statement. Then look at the C option. Family history is not a risk factor for POAG. Now, they are actually telling you with respect to conversion of ocular hypertension in POAG. So, family history is not a risk factor as far as the conversion from ocular hypertension to POAG is concerned. Yes, isolated, it is a risk factor. We have the like family history, diabetes, hypertension. I did told you here everything. So if you see here, we have got so many things. These all are risk factors of the POAG, but they are not having the extra risk from the ocular hypertension to POAG conversion. So in that respect, if I say, then this statement is also true. It is a risk factor, but it is not a risk factor for the conversion of ocular hypertension to the POAG. So by default, now you are left with the D option. Increased CD ratio is a risk factor for the POAG development. Now, increased CD ratio is definitely a risk factor for the POAG development. If I have increased CD ratio, that is more than 0.7. So, if I have more CD ratio more than 0.7, then definitely I have more and more chances of this conversion, okay, from the ocular hypertension to POAG. So, this is a perfectly true statement. This is perfectly a true statement. So if I have to say one of the statements, if I have to choose only that which of the false statement, then in that respect I will say that C is an option, because they are saying that family history is not a risk factor for POAG. So definitely family history is a risk factor for POAG, but it is not a high risk factor for the conversion from the ocular hypertension to POAG. So it is the most fitted answer out of the all. Otherwise, if I see with respect to POAG, then it is a from the ocular hypertension conversion to the POAG, then even this statement is true. Okay, but I think you should realize this, that marking the answer is always relative. If you have more 3 more correct answers than the one that is less correct, will be your answer. So reducing IOP is effective in delaying the incidence of POAG. Definitely true. Thin cornea is a risk factor for POAG development. This is true. Family history is not a risk factor for POAG. And increased CD ratio is definitely a risk factor for the POAG development. So I hope you got the idea and the approach how to solve these questions, and in future we are expecting to get the better options. All right. Now, the iconic question, I think I have told you millions times in the classes also, that Wilson's disease and the KF ring is very, very important. Again, this was also a part of our important list. So let's see what are the questions they have asked about the KF ring. They are asking you the true statement regarding the KF ring. What is KF ring? It is the Kayser-Fleischer ring, that is. And where you get this? You get this in the Wilson's disease. Okay, Wilson's disease, where you are getting the inborn error of the copper metabolism. So this is an inborn error of the copper metabolism where you are getting the KF ring, and it is associated with the low levels of the ceruloplasmin. Low levels of the ceruloplasmin, and due to the low levels of ceruloplasmin, we have copper deposition. What is this called as? This copper deposition is called as the chalcosis, and due to this you get a cataract. What is the name of that cataract? Sunflower cataract. So sunflower cataract, as I always say, is one of the fancy names of the cataract, and fancy names of the cataract are again quite important, asked so many times. What are the other causes of sunflower cataract? Other causes are, if you look at the DD, we also have the penetrating trauma. Penetrating trauma is also there, and then we have got the copper deposition. The chalcosis in general also can actually lead to this sunflower cataract. Now, though we are getting the sunflower cataract here, but one thing is worth mentioning, that the most common ocular feature, if they ask you the most common ocular feature of the Wilson's disease, then it is not the sunflower cataract, it is the KF ring only, which is named after the two scientists. We have the Bernard Kaiser and the Bruno Fleischer. Bernard Kaiser and the Bruno Fleischer, these were the two friends who discovered about this, and that is why it was called as KF ring. Okay. Now, don't get confused with another thing that is called as the Fleischer ring. We also have one more ring that is called as the Fleischer ring. Fleischer ring is found in the keratoconus. And in the keratoconus, we are getting at the base of the cone. At the base of the cone, we are having, and what kind of deposition we have? Iron deposition. Here you are having the iron deposition. And which layer? In the epithelium. See, these depositions are always very important with respect to the layers of the cornea. Like if you talk about this KF ring we are getting in the Descemet's membrane. This we are getting in the Descemet's membrane. While if you talk about the Fleischer ring, that is found in the epithelium, then in the KF ring you are getting the copper deposition, while here you are getting the iron deposition. Similarly, do you remember the Stocker's line? The Stocker's line is also the iron deposition that you get in pterygium. Okay, now if I talk about the options, let's look at the options first, what they are trying to say. First of all, they are saying it is pathognomic of the Wilson's disease. So this is actually a wrong option. It is not pathognomic. It is the most prominent ocular feature of Wilson's disease. It is the most common feature of the Wilson's disease in the eye, but it is not pathognomic, because pathognomic means that it is exclusively found in the Wilson's disease. If I am getting KF ring, that means Wilson's disease, that's it. So it is not like this, because you can get this in the primary biliary cirrhosis. I think Robbins tells you this. So we have got this KF ring in the primary biliary cirrhosis as well as the chalcosis. So therefore, I cannot say that this KF ring is entirely pathognomic of the Wilson's disease, number one. Number two, they are saying that it is seen in the superior and inferior Descemet's membrane. So actually, this is to start with. If you remember, in the band shaped keratopathy also, I told you that we do not get the band abruptly. So if this is your eye, okay, so we get the deposition starting from here, and then somewhere after some time they are merging to form the total band. So this takes place horizontally in the cases of band shaped keratopathy. But when it comes to the KF ring, what happens? We have the golden brown. we have got the golden brown ring. So we have this ring first located in the superior and the inferior quadrant, something like this. See, I have got a pic also. So can you see in this pic that you have the deposition that is present, see, superiorly and then inferiorly. Afterwards it will come like this also and like this also. So first you are getting these vertical or the superior and inferior. From superior and inferior also I can say first it is superior and then it is inferior. So deposition is taking place in this order. It is first superior, then inferior, and then the nasal and temporal. So this is absolutely correct answer, and its color is golden brown in color. It is golden brown in color, and it looks greenish actually. It looks greenish, actually it is golden brown in color due to the cobalt blue filter, because you are looking it through the cobalt blue filter, that is why it is appearing greenish, but otherwise it is golden brown in color. So that means this statement is right. This statement is right that it is seen in superior and inferior Descemet's membrane. Now see the option number C and D. It is seen in all patients with a neurological involvement, or it is seen in all patients with hepatitis or hepatic involvement, whatever it was. So if you go by the standard textbook, see, data always vary if you go with the different books. So but near about, you can say the range I can say. So in the neurological involvement it is 95 to 100%. While if I go with the hepatic involvement, it is about 65%. So those people who are having the KF ring, okay, you are getting them along with 95 to even 100% of the patients with the neurological involvement. So if I have something having 95 to 100, I think I can go with this all. All means practically all, 95 to 100% of the patients who are having the neurological involvement will also show you the KF ring. So this is also the right option. Okay. Now if you look at the D option, seen in the patients with the hepatic involvement, again they are saying all. So this is actually wrong. It is not all. I think this is about 50%, because some books say 30%, some say 40, some say 50, some say 60. So even if I take the maximum value, that is 65%, and that is far away from the all. So this statement is wrong. It is not associated with all the patients who are having the hepatic involvement. Now look at the option number E. Disappears with the desferoxamine. Now this statement is partially wrong. It disappears. Now this is correct. It is disappearing. This is correct. Means this is reversible. The KF ring is reversible. This is correct, but it is not reversible with the desferoxamine. It is reversing with the D-penicillamine. D-penicillamine. So therefore this statement is again wrong. So what are the right choices in this question? It is B and C. It is seen in the superior inferior Descemet's membrane, and it is seen in all patients with the neurological involvement. Right? Now one more thing. Can you see? This is actually the gonioscopy. Gonioscopy. And can you see these deposits? So this is actually showing you the early KF ring. Early KF ring on the gonioscopy. When you have the late KF ring, when you have got the superior inferior quadrants made, or when you have total ring made, you can see it on the torchlight, or you can see on the slit lamp examination. But the early KF rings are not visible on the slit lamp examination. They are visible by the gonioscopy. What was gonioscopy? Gonio means angle. So angle of anterior chamber, and scopy means the visualization. Scopy means the visualization. So visualization of the angle of anterior chamber is actually called as gonioscopy. And you know what are the structures that are visible in the angle of anterior chamber? There are 5 structures. We have the root of the iris. Okay, then we have ciliary body band, then scleral spur, trabecular meshwork, and then we have the Sholby's line, and then we have the Sholby's line. So if I talk about this Sholby's line, what is Sholby's line? It is the termination. This is actually the termination of the Descemet's membrane, and Descemet's membrane may show the KF ring. So that is why whenever we have got the early KF ring, they are just located in the ends of the Descemet's membrane, so they can be seen on the Sholby's line, and the Sholby's line will be seen only on the gonioscopy. So sometimes even this question could be asked that if you are suspecting the KF ring but you cannot see it, then what else you can do? You can do the gonioscopy and you can confirm it on that. All right. Okay. Now the next question, which of the following are used for the diagnosis of fixed dilated pupil? Now this is a very simple question that we discussed in the flowchart of an isochoria. The only problem is I think there was some problem. The two options were same, or with the pilocarpine, or they were not showing some concentration, but as a common sense we have taken the two concentration, 1% and 0.1%. So let's discuss that chart and then we will come back. Okay, because I am more interested in telling you about the details of the anisocoria, how to go about it, because certainly it is an important topic and I am actually expecting one question from there. So let's get started. If the patient is having anisocoria, okay, if the patient is having anisocoria, now first of all, what do you mean by anisocoria? If there is a difference of more than or equal to 0.4 mm between the two pupils. If the two pupils are differing in size by 0.4 or more, then we can say that this patient is having anisocoria. So even the definition itself is important. Now how to interpret it? You have to see that whether this anisocoria is increasing in the dark conditions or whether this anisocoria is increasing in the lighted condition. Okay, so you have to see this one by one. So first see if it is increasing in the light. Anisocoria increasing in light. So that means that the normal pupil is constricting when it is facing the light, but the one which is abnormal is not constricting. So when there is an anisocoria and the light is shown, the normal one is even more constricting and the abnormal one is not constricting. Obviously this will increase the difference in the size and we will have more of an anisocoria. So what is the next thing that you should do? You have to look for the ocular motility. So this will also help you in getting your clinical processing done. In some questions, we have comprehension analysis type of questions, clinical based questions. So in the comprehension and analysis type of questions, you have to see what are the next questions you are going to ask. So look for the ocular motility. If the ocular motility is abnormal, then we are suspecting the third nerve palsy. Okay, because you know that all are supplied by third nerve except for SO4 and LR6. So we are suspecting the third nerve palsy. Now if I am having the normal ocular motility, then I have to see the shape of the pupil. Then look at the shape of the pupil. Okay, now again we have got two options, whether it is normal or whether it is abnormal. So if I have abnormal shape, okay, if the pupillary shape is abnormal, then I will suspect the iris damage. So we can have trauma, surgical trauma or blunt trauma, due to which the iris damage is there. But if you still have the normal shape of the pupil, now what you are going to do? Now if you have the normal shape of the pupil, then you give the 0.125% pilocarpine. So this is the first concentration, see, that I am using here. This is 0.1%, 0.1 to 5% pilocarpine. This is very, very diluted form. So this is very, very diluted form of pilocarpine. So when you give this pilocarpine, there are only two options. Either the pupil constricts, or it is showing no constriction. Okay, so if the pupil is constricting, then the diagnosis is very, very clear. Then it is the AD's tonic pupil. AD's tonic pupil. Then this is very, very clear, because you know in the AD's tonic pupil we have got a lesion in the ciliary ganglion. So because you have a lesion in the ciliary ganglion, okay, so we have got what you call as the denervation sensitivity, and therefore it is the only type of pupil which is constricting with such a diluted version of pilocarpine which is there. Okay, now suppose it is not showing the constriction. So if the pupil is not showing the constriction, then you give the 1% pilocarpine. Okay, then we give the 1% pilocarpine. So this should be the second dosage of pilocarpine that have been used in the question. Now again there are two possibilities. Now you get the constriction or not. So if the constriction, look for the constriction now. So if you have the constriction present now, again it can be a case of third nerve palsy. But if it is absent, it is not even constricting with a 1% pilocarpine, that means it is a case of the pharmacological blockade. So see, we have got so many things which have come out here, whether it is a case of the AD's tonic pupil or pharmacological block, or it's a third nerve palsy, or it's a iris damage, and what are the concentrations of the pilocarpine that you can be using. Okay, now the second option, if you look here, second thing was that if the anisocoria is increasing in the dark, then what is there? So if it is increasing in the dark, this means two things. That means the normal one is dilating, normal pupil is dilated, but the abnormal is showing no dilatation. Now abnormal is not showing any dilatation, that means the problem will be in the dilator pupillae. What is the dilator pupillae muscle? Dilator pupillae muscle is the muscle responsible for the dilatation of pupil, and this is actually supplied by the sympathetic supply. This is supplied by the sympathetic supply, and this sympathetic supply is inhibited, it is paralyzed in the Horner syndrome. Therefore, in this person, we are suspecting the Horner syndrome. So, another important thing, this question was also asked in your AIMS June 2020, that there was an isocoria that was increasing in the dark conditions. Why? Because it is a oculosympathetic palsy. This is a oculosympathetic palsy, and therefore we are suspecting the Horner syndrome here. Now, what are the things that you should look for? So, you should look for the ptosis also, then you should look for the dilatation lag also, then you will further come to know that this is a case of Horner syndrome only. Now, what are the things that you should do to confirm it? So, in order to confirm the Horner syndrome, we can use the 1% apraclonidine. Okay. Either I can use 1% apraclonidine, or I can use 4% cocaine. Okay, or I can use the 4% cocaine. So 4% cocaine is also given in the options, and pilocarpine, two options were also given, most probably 0.1 and 1%. Now, which of the following should be used and why? So basically, if you see, this apraclonidine is preferred. Apraclonidine is preferred. There are two reasons for it. Ek to, it is not an abusive substance, and secondly, it is showing a positive response in Horner syndrome. So if I give this apraclonidine, okay, what you will do, then you look for the dilatation. So if it is a normal pupil, there will be no dilatation. While if it is a Horner syndrome, the dilatation will be present. So due to these two reasons, we are preferring this 1% apraclonidine because it is showing a positive response in the affected eye, and secondly, it is not having any substance abuse. But the problem is that this 1% apraclonidine is actually contraindicated in the infants. You cannot use this drug in the infants. If you remember, this happens with the brimonidine also, that is also a CNS depressant. Here this is contraindicated because of the respiratory depression. So if I am having the infant and I have to check this, then in that case I will be using this 4% cocaine only. Now once you have confirmed the Horner syndrome, then you can give 1% amphetamine. Okay, so 1% amphetamine now they are giving, and what it is going to do, you can now demarcate that whether this Horner syndrome is pre-ganglionic or it is post-ganglionic, whether it is pre-ganglionic or post-ganglionic. So in pre-ganglionic, the dilatation will be present, while in the post-ganglionic, no dilatation. There will be no dilatation. So this is the total, flow chart through which you are able to solve any abnormal pupillary reaction from here. You also know the agents, then which of the following are used, and what is the, definitive interpretation if you are using them. Now what they have asked is pretty simple. They have just asked that which of the following is used for the diagnosis of the dilated pupil. So if you look here, pilocarpine. So if I have a dilated pupil, I can use this pilocarpine 1%. I can use this pilocarpine 0.1% also. Okay, but I will not use the adrenaline or phenylephrine. Why should I use them? Because phenylephrine is just a it is just a midriatic. It is just a midriatic, and there is no cycloplegia. There is no cycloplegia here. So I do not have any cycloplegia. So this is a midriatic. Now already we have a dilated pupil which is fixed. So you will not use phenylephrine. Phenylephrine we are using for the retinoscopy. If I want to do the retinoscopy, and that too in the patients who are more than 60 years of age, because those people have already ciliary muscle weakening and aging is there, so I don't want to paralyze, maybe it will not gain back its tone. That is why we are preferring this phenylephrine to be used after 60 years of age. Then we have adrenaline. Adrenaline is a sympathetic supply, so this will further dilate, so this will also act as a midriatic, so obviously there is no use. Okay, now as far as the cocaine is concerned, so again there is no use of using cocaine here. So we have got two options, right? Which of the following will be used for the diagnosis of a fixed and dilated pupil? I want to constrict it and see whether it is constricting with 0.1 to 5%. If it is constricting, then it is the edystonic pupil. If it is not constricting, then we will try with the 1%. So both of the answers are right. So answer will be the A and E. So now in both the chances, if the concentration was given, then also both the pilocarpines answers are correct. If the options were not containing the concentration, then also again both the options are correct because both were same. So answer will be A and E. Next question, the nerve causing the movement of the eyeball are all except. Now this is again a very simple question. Like students told me that they got a cadaveric section showing the base of the skull with so many nerves, and this is one thing that they are asking continuously. And as I always say that this thing will help you like anything. You should know that all of the extraocular muscles are supplied by the third nerve except for SO4 and LR6. So what we say, it is the third nerve, fourth nerve and the sixth nerve which are usually responsible for the ocular motility. Okay, now if you look at the options, now here I have written the names because I do not know what structure they had marked ABCD, but supposingly they have marked A as optic nerve, B as the oculomotor nerve, C as a trochlear nerve and D as a abducent nerve. So in that case your answer will be A, optic nerve, because you know optic nerve is your afferent nerve. This is the afferent nerve not only for the visual pathway, it is the afferent nerve not only for the visual pathway but also for the pupillary reflexes. For the pupillary reflex pathway also, this is the afferent nerve. So if the optic nerve is not intact, then we are getting what you called as RAPD, then we are also getting the complete anopia on that side or the complete blindness on that side. So optic nerve has nothing to do with the ocular motility. So you should be well versed with the anatomy. Okay, what are the nerves going on, what are the canals in the foramen? So this is your related anatomy part. You should be thorough with them. As far as the ophthalmology part is concerned, you should know this, that all the extraocular muscles are supplied by the third nerve except for SO4 and LR6. So for the ocular motility, the nerves that are required will be third, fourth and sixth, right? Okay. Now coming to the next question, which of the following statements are true statements? So you have to look for the true statements, and these statements are actually asked with respect to POAG. Okay, so again a question on POAG. So let's look at the options. The blockade is at the level of TM is seen on gonioscopy. What they are saying, that in open angle glaucoma you are able to see the block at the level of trabecular meshwork. So now this is a tricky question, because when I say, if you remember, when we classify the glaucoma and we draw the diagram, these are the layers of the cornea, and this is your iris, the ciliary body, the lens. Okay, and you know that from the ciliary processes is the formation of the aqueous humor. So this aqueous humor is actually passing through this pupil. It is coming in this anterior chamber. Okay, and then it is passing through this angle of anterior chamber. Okay, and then it is passing through this sieve like meshwork. Then you have got a oval canal, then you have got this aqueous vein, and then we also have the episcleral veins. Yes, it is something like this. So whenever we have some problem here, this is called as the angle closure glaucoma. Then this is called as an angle closure glaucoma, when you are not able to see any of the structures which are lying in the angle. So I told you that what were the structures, like we have the root of the iris, then root of the iris, ciliary body band, scleral spur, trabecular meshwork and the shawl base line. So if any of these structures are not visible, there are chances that there is a obstruction in the flow of the aqueous humor, and that is called as the angle closure glaucoma. Then we say that if there is some blockade, at the level of the trabecular meshwork, so trabecular block leads to the open angle glaucoma. Yes. Now this is a tricky question, because they are saying that you are able to see this trabecular meshwork blockade at the level of gonioscopy. So this is wrong. You are not able to see the blockade at the level of trabecular meshwork in the gonioscopy. What you are seeing on the gonioscopy, I am able to see the trabecular meshwork, but I am not able to see the block. Moreover, if I talk about the primary open angle glaucoma, okay, now when I am seeing the block, that block is actually seen due to the secondary open angle glaucoma. So in the secondary open angle glaucoma, like it can be inflammatory glaucoma, or it can be a pigmentary glaucoma, or we can have the phacolytic glaucoma, or we can have the phacotoxic glaucoma. So whenever we have the known cause of the blockade of the trabecular meshwork, then you are seeing, but again that is not seen on the gonioscopy. Second important thing is that when I'm talking about the primary open angle glaucoma, so you have no known cause, no known cause for the trabecular blockade. So I am not having any known cause for the trabecular blockade, so I am not able to see any blockade. Otherwise too, I am not able to see the blockade on gonioscopy. I am able to see only the trabecular meshwork. Then the third important thing is that what is actually the main problem that you are getting in cases of open angle glaucoma. What you are getting is actually the trabecular sclerosis and not the blockade. So we are getting the trabecular sclerosis, that is the thickening. This is the thickening which is seen at the level of the trabecular meshwork, and due to this thickening, what is happening, because you are having the thickening at the trabecular meshwork, there will be, a closing of the trabecular spaces. So there will be closing of these trabecular spaces, and due to the closing of these spaces, there will be decrease in the aqueous outflow. So basically it is the decrease in the aqueous outflow which is taking place in the open angle glaucoma due to the trabecular sclerosis thickening, and this is due to the unknown cause. We do not know what is the exact reason why we have the thickening, but we have the thickening and that leads to decreased aqueous outflow. So this option is wrong. Then the second option is family members are at 1% more risk of developing the open angle glaucoma. Now we already know that open angle glaucoma has this tendency. If I talk about the primary open angle glaucoma, then it has a genetic predisposition. It has that genetic predisposition. Okay, and therefore we have a strong family history. We have got gene mutations which are responsible. So we have got what you called as the optineurin. These are the genes which are responsible. Then we have the myocilin, and then we have the WDR36. So these are the genes which are actually responsible, which are located on the chromosome number 1. So these gene mutations are responsible for the causing of the open angle glaucoma, and certainly the family members are at risk. So if I talk about the family members are at risk of glaucoma, but it is 10 times more risk as compared to the persons who are outsiders. If I talk about the siblings, then in the siblings it is the 4 times more risk. So the 1% is actually wrong. If I talk about the family members, there is 10 times more risk of having the open angle glaucoma. For siblings it is 4%. Then if you look at the option number C, on dilating the pupil, IOP always rises. So again, if you remember, we always make a flow chart for this. If you remember, this is the eye, okay, and this is the iris, something like this. We have the ciliary body, and this is the lens here. Okay, now what is happening, if you look at the aqueous humor which is coming from the ciliary processes, it is flowing through this pupil, something like this, coming in the anterior chamber. Then from the angles, it is passing through the trabecular meshwork. So this is actually normal. Normally this is happening whenever the aqueous humor is released, passing through the pupil and passing through this angle of anterior chamber through the trabecular meshwork. Now whenever we have the mid dilatation of the pupil, whenever we have the mid dilatation of the pupil, then what happens actually, we have got something like this. This is your lens. Okay, so now what is happening, there is not only dilatation of this pupil, it is also going backward and having an opposition towards the equator of the lens. So this is actually called as iridolenticular. iridolenticular apposition. This is called as iridolenticular apposition. Now, whatever amount of aqueous humor is released from the ciliary body will not be able to pass into the anterior chamber. So, what is going to take place is the aqueous collection. So, there will be aqueous collection behind the iris. Now, due to this aqueous collection behind the iris, we have a lot of pressure building up behind the iris, and a time will come when this will push the iris anteriorly. So, as soon as the iris is pushed anteriorly, what is going to happen? Something like this. So, this iris is pushed anteriorly like this. This iris is also pushed anteriorly like this because of this aqueous humor pent up pressure. So, what is happening? This is something what is called as the iris Bombay formation. This is called as the iris Bombay formation because we have got ballooning of the iris towards the cornea, and we have the iridocorneal contact, and we have the iridocorneal contact which lead to the sudden attack of, this is leading to sudden attack of the acute congestive glaucoma. So, all this is taking place. This is true whenever there is actually pupillary dilatation, there is IOP increase, but this is not for the open angle glaucoma. This is for the angle closure glaucoma. So, if this takes place chronically, there can be formation of pars. This is your peripheral anterior synecdoche, and due to the formation of this synecdoche, we can have the synechial angle closure glaucoma, synechial angle closure glaucoma, and this is a kind of what you called as chronic congestive glaucoma. This is a kind of chronic congestive glaucoma. So, this is the whole cycle that is taking place due to the pupillary dilatation and the rise of IOP, but it is not due to the open angle glaucoma, it is the angle closure glaucoma. So, come back to the question now. If you see here, so option number C, on dilating the pupil, IOP always rises. So, this is a wrong option with respect to the PUAG. Now, if you see the D option, visual field defects can be there with the normal CD ratio. Now, this could be there. Why? Because I told you that if you look at the triad, we can have the triad. So, in the triad, I have the raised intraocular pressure, I have the optic disc changes and the visual field defects. And what I said that even if two of them are present, I will call it as glaucoma. So, if I have the raised intraocular pressure, okay, and I have the visual field defects, then also I can have glaucoma even if I do not have the optic disc changes. Now, the question is that how come then the visual field defects are there? Okay, sometimes when you are thinking more, then also that creates a problem. How you can get the visual field defects when you are not having the optic disc changes? They can be the early changes. If I am having the early changes in the optic disc, so what happens when there is early changes in the optic disc? These changes are taking place at the level of the nerve fiber layer. Now, because these changes have not reached up to the inner part, so they are not affecting the CD ratio there, but they are there so that they can be causing the visual field defects. That is why this statement is actually correct. One can have the visual field defects even in the presence of the normal CD ratio, right? Now, looking at the option number E, first degree relatives have more chances of steroid response. Now, this is again the right option. It is true. Now, what is the meaning of this? Steroid response. So, if you remember, I always tell you one mnemonic, that is GTCS. Okay, we always do this mnemonic. That means the topical steroids have more chances of glaucoma, while the systemic steroids have more chances of cataract. That means those people who are actually taking the topical steroids, those patients who are taking the topical steroids, they have the chances that there can be raised intraocular pressure, and these people are called as the steroid responders. These people are called as the steroid responders, and obviously there are more chances, if there is a family history of glaucoma, then there are more chances that this person will be behaving more as the steroid responders. Okay. Therefore, the answer to this question is D and E. We have got the visual field defects that can be there with the normal CD ratio, and we have got first degree relatives, because you know glaucoma has a genetic predisposition, and we have always the risk in the first degree relatives as well as the siblings also. That is why the first degree relatives also have more chances of being the steroid responders. So that's all with the ophthalmology questions. I hope you understood them, and I have tried to take the topic at large, because actually it is not the question, it is the concept that is important, it is the topic that is always repeated, and it is the approach that is important towards the question what you are taking, and obviously the knowledge goes by. So looking at the topics, so your must to do topics, okay, try to do the glaucoma, try to do the all the high yield points and the high yield topics that I have already given you the list. They are there on your groups. Okay, try to go through them. And one more thing I'll say, that I know your paper has been postponed, energy levels low, and this always happens when the paper is very near. We all are saying that, oh, we have very less time, maybe if I had 1 month more I would have done wonders, and but now I don't have time. And suddenly when they say that, okay, you are granted and take more time, and then again we are said that, oh, I do not wanted that much of time. See, so this is life, and life is actually unpredictable, and things will not happen as per you. They were not happening as per you, and they will not be happening as per you. Let's take it for one say. So you should be ready as it goes. Show must go on. So the day you start, adapting yourself to the changes, change is constant, so if you are adapting yourself to the change, I think nobody can be more successful than you. So take that extra time as an opportunity. Oh, you were cribbling for time, and now you have time. Look at your weaknesses, look at the topics, look at the subjects that you were not confident upon, and give your best. That, like nature has given you, God has given you one more time to give your best, so that afterwards you do not have that regret in my mind that I could have done extra, I could have done better, I had time but I have not done. So give your very best attempt this time. Thank you, and happy ophthalmology.